Dr. Randall Hand, who will be talking about pridopidine studies and top-line results from the phase 2 Healy platform trial. Dr. Hand, please.
Hi, everyone. I will be providing the presentation for Prilenia. My name is Michal Geva, and I'm head of research. So should I just share my screen here, or?
Yes, please.
My slides? Okay. Just please let me know if you can see my screen. I'll put it in a presentation.
Yes, perfect. Perfect.
Okay. Thank you. Thank you very much. So yes, my name is Michal Geva, and I'm head of research at Prilenia Therapeutics. I would like to thank very much the organizers for the opportunity to be here and to present our recent findings from pridopidine regimen D from the Healy ALS platform trial. So pridopidine is a novel small molecule. It's taken orally twice daily, and it acts as a highly selective and potent sigma-1 receptor. sigma-1 receptor agonist. Pridopidine is currently in advanced clinical development for the treatment of ALS as well as for Huntington's disease, but today's focus, of course, will be on the development of pridopidine for ALS. So first of all, I would like to show you that the target engagement of pridopidine was confirmed using PET imaging data, which assessed the sigma-1 receptor occupancy by pridopidine in the human brain. The selective sigma-1 radioligand fluspidine was used for this purpose. As you can see on the top panel here, fluspidine, when it was injected IV to healthy volunteers as well as HD patients, was able to enter the brain and shows the expected wide distribution of sigma-1 receptors in the brain. However, when these healthy volunteers and patients were pre-treated with pridopidine at the clinical relevant dose, there was almost complete inhibition of fluspidine from binding to the sigma-1 receptor. And this really indicates that pridopidine, first of all, enters the brain, the target organ, and have over 90% sigma-1 receptor occupancy. We also wanted to assess the selectivity of pridopidine, and for that purpose, we performed a similar experiment, but have used a selective radioligand for the dopamine D2 and D3 receptor, which is called falopride. When we used falopride, we saw a negligible occupancy of about 3%. So really, this shows us that pridopidine has a selective and robust sigma-1 receptor target occupancy in humans. So the sigma-1 receptor is an intracellular protein, which is highly expressed, which is highly expressed in the brain, specifically in the cortex, brainstem, and spinal cord, which are areas, as you know, are implicated in ALS. Activation of the sigma-1 receptor has shown in the literature to have neuroprotective effects. It is known to reduce neurodegeneration of neurons, increases energy production, enhancing mitochondrial function, enhancing autophagy, increasing neuronal connectivity, and overall reduces cellular stress and neuroinflammation. So the implication, sigma-1 receptor implication in ALS has been seen in preclinical models. And for example, here in SOD1 mice who also lack the sigma-1 receptor, so are also sigma-1 receptor knockout mice, there is exacerbation of disease progression compared to SOD1 mice with a normal sigma-1 expression. And here you can see this with reduced survival in the SOD1 sigma-1 receptor knockout mice. Another very important validation for the sigma-1 as a therapeutic target in ALS comes from human genetic studies. And these studies shows that actually mutations in the sigma-1 receptor cause ALS. We know that these are very rare, but we know that complete loss of function mutations cause a juvenile early onset ALS, while partial loss of function mutations cause late onset adult ALS. So based on, so of course, we and others have also shown in numerous preclinical ALS models that pridopidine has improved central features of ALS. So in mice, it improved the body weight loss, it prevented muscle fiber wasting, and had an improvement in motor coordination. And we were also able to observe increase in neuromuscular junction, and also in neuromuscular junction function. We saw increase in axonal transport, reduction of SOD1 aggregates, and also improvement of neuronal and motor neuron survival. So really based on the above and much more, pridopidine was chosen to be assessed in the Healy ALS platform trial, and we were selected as regimen D in the platform trial, and you can see us here in gold. So I'm sure everyone knows a lot already about this platform trial, but basically each regimen had a 1 to 3 randomization, and then we had a placebo shared arm. So key eligibility criteria included patients with ALS Correal of the full spectrum, possible, probable, lab supported, and definite. It also included patients with an onset of up to 3 years, so pretty much also advanced patients were included, and also patients with an SVC of 50% and above. In terms of safety, we were very happy to see that there were no safety issues at the clinical dose of pridopidine, which was given at 45 milligrams twice daily. And this is very much in agreement with what we know with extensive safety profile of this drug that was also tested in Huntington's disease. So you can see really comparable safety profile between placebo and pridopidine. So in the Healy platform trial, the primary endpoint in the full database was looking at the changes in ALS FRSR to week 24. And there were also some pre-specified analyses that were specific to our regimen as well as for others. And we also had pre-specified additional subgroups. So we looked at speech measurements, in addition, of course, to endpoints of interest, which included respiratory, bulbar, the quality of life, and NFL. We had pre-specified analysis of a subgroup of definite ALS, which are also early with less than 18 months in symptom onset, and also did post-hoc analysis on additional subgroups, which were also fast progressing, as determined by the pre-baseline slope of -1 and above. So for the primary endpoint in the full analysis set, pridopidine showed no significant benefit, and there was no benefit in the full analysis set for pridopidine versus placebo, and the primary endpoint was not met, as well as the key secondary endpoints. However, we did want to look specifically at those patients that had baseline criteria which were more similar to other successful trials, and more specifically, as I mentioned, to patients which are specifically definite or definite and probable, had an early onset of symptoms of below 18 months, and had a faster progression as was measured by the pre-baseline slope of the ALS FRSR. So if we look at those 3 studies, the Relyvrio, Radicava, and Tofersen, we can really see that all had time from symptom onset between roughly 8 months up to 14 months symptom onset. All were relatively faster progressors and included either definite or definite and probable. And when we did our subgroup analysis of patients who were definite, probable, less than 18 months, and faster progressors, we did end up with a small sample size. However, now we had our baseline criteria, which were similar and matched those other studies which had a positive outcome. So when we compare the subgroup analysis from the platform trial, we can see that we had a similar duration of 24 weeks. In this group, we had between 10 and 11.5 months symptom onset. We looked at faster progressors, and in this subgroup also only looking at definite and probable. So no possible and no lab-supported probable patients. And then we saw some very consistent and interesting results, which were really across different endpoint measures. So for the ALS-FRSR total, as I mentioned before in the full analysis set, we did not see any significant benefit. However, when we started looking at those patients who were definite and early, and this was a pre-specified subgroup, and further looking at the post-hoc on the definite, probable, early, and faster, we started to see a positive increase in treatment benefit of pridopidine versus placebo. And what you see here is the delta. So that's the LS mean difference between pridopidine and placebo at week 24. So it was 2.4 and even reaching 5.2 with a nominal p-value at this early and fast group. Similarly, when we looked at the respiratory subdomain, for the full analysis set, there was some numerical benefit with a p-value of 0.09. And again, as we went to those who were early and definite and early, really we saw an improvement and a larger effect size of pridopidine, although the sample size was getting smaller. And here, even in the post-hoc analysis of definite, probable, early, and fast, we could reach, p-values which were very impressive and an even stronger magnitude of treatment effect. Interestingly, also, we saw that the effect of the ALS-FRSR respiratory dyspnea subdomains was very much improved and very much drove the benefit on respiratory. And this was already evident in the full analysis set, where we got a positive treatment effect and even stronger treatment effects when we looked at those pre-specified and post-hoc analysis of subgroups of interest. And this is despite smaller sample sizes. So interestingly, speech was very important, and I'm sure everybody here knows how speech is highly clinically meaningful and relevant endpoint in ALS. It is well known that speaking rate, for example, is significantly associated with different measures of overall ALS progression and bulbar disease severity. So we used speech measured as a quantitative measure that have high reliability, validity, and also it is very critical in determining the appropriate timing of intervention, because this is something that really affects the majority of the patients, and an objective speech measure may become even more sensitive than functional decline. So in the Healy platform trial, we have used the oral analytics speech device, which recently received FDA breakthrough designation. So I'm showing you here data which were very much encouraging, and this data was observed in the full analysis set already. Using a quantitative and very sensitive measure, we were able to see treatment benefit in speaking rates, positive treatment benefit with a p-value of 0.027, also a similar positive treatment benefit with articulation rate, also with a significant p-values, and positive treatment benefits also in other measures, including phonation and articulative precision, which all went in the same direction, so showing treatment benefits. Interestingly, when we then looked at those same subgroup of interest, the effect was again much stronger. Treatment effect increased as we went early and faster, and p-values were very strong, so 4 or 5 knots here. We were, of course, very interested to see how this all contributed and was affecting a patient's quality of life. So the quality of life is an index of 5 different subdomains, and we were very interested in looking, of course, in the total, but in this specifically 2 subdomains of communication, eating and drinking, which are all correlated and have connection to respiratory and speech. So for the ALS AQ40 total, again, in the full analysis set, we could not observe any benefit treatment, but when we went early, definite and early, there was a very strong treatment benefit that was observed in the definite and early subgroup. And this was also the case when we were looking at the communication subdomain. Again, as we went early, definite and early, the effect size really showed a robust increase. And of course, the same also with the ALS AQ40 eating and drinking. So this really shows convergence and everything going in the same direction. So NFL was also an exploratory endpoint in our study. So NFL, as you all know, is a protein which is released from neuron during degeneration. And specifically in ALS, NFL levels are higher, of course, compared to healthy control. And they tend to be after symptom onset, relatively stable over time. However, we also know that higher NFL levels correlate with faster rate of disease progression. So post-hoc analysis of those subgroups, which are definite, probable, early, fast, and then at the end, the subgroup that showed the most robust treatment effect, the definite, probable, early, and fast, we observed trends for lowering of serum NFL levels. The trends were there, but they were non-significant. And we are now actually currently reanalyzing or planning to do some additional analysis, as there was quite a lot of variability in the results of the serum NFL levels. In addition, the Healy had performed a survival analysis. Of course, this was also a post-hoc analysis, and the survival was done on our regimen only, where we looked at only those patients that were randomized into the regimen D, into regimen D. It was estimated by Kaplan-Meier with 95% confidence interval. So what you see here in red, this was kind of a delayed start, because in red you see the patients that were on pridopidine for the double-blind period and then maintained on pridopidine also for the open-label study. And in blue, you can see the group that were on placebo for the first 24 weeks and then went into open-label and received pridopidine. So after 180 days, which basically we see no, as expected, no death and no changes in survival. At 300 days, and this is already in the open label, 300 days were the 50% survival probability for the placebo delayed start group. And 300 days for the pridopidine early start group, we had a survival probability of 85%. So looking for, showing us robust benefit. It took additional 10 months at 600 days to reach the 50% survival probability for the early start pridopidine. So this is really reflecting almost doubling of the survival of the time in this subgroup, which is definite and probable and early. So in summary of the results, the primary and key secondary endpoint in the total population, which includes also late patients, there was no benefit for pridopidine. However, in additional pre-specified analyses, which were definite and early, as well as post-hoc analysis on fast progressors, we did see significant benefit in numerous endpoints consistently across the measures. So ALSFRS-R total, there was slowing of decline. We saw slowing of decline in the respiratory, in the bulbar domain, quality of life, and very encouraging results for the quantitative speech characteristics. Some of them had showed nominal significant benefits for pridopidine in the quantitative speech already in the full analysis set. Post-hoc analysis did show trends for reduction in serum NFL. The greatest reduction was observed in the faster progressing participants. We confirmed no safety signals which we had expected and also saw before in other studies. And very encouraging also, the survival post-hoc analysis showed clinically meaningful benefit for the subgroup of those that are definite, probable, and early. These observations are very much encouraging, and we are now very busy planning the phase 3 study based on these results. I would also, of course, really want to thank everyone at Mass General Hospital and the Healy, which just recently got a grant supported by the Act for ALS in collaboration with us, which is going to give access to pridopidine to expanded access program, where we will be able to treat approximately 200 ALS patients in this program. So also huge effort from all the teams supporting, hopefully making this drug available to patients. I'm very happy to take any questions. I don't know if I should keep my slides up or not.
Sure, thank you. No, very exciting work. I think you have time for one or two questions. I might kick off with just one, and it's the following. So it's very impressive, as you pointed out, that there's a dose response in terms of human genetics and the impact of this receptor, which is to say that complete loss of function is juvenile onset, partial loss of function is adult onset of motor neuron dysfunction. Let me ask you this related to that observation. To what degree does pridopidine augment the function of the sigma-1 receptor? And there may be many pathways that one could use to answer that question. But overall, what is your sense of the increment in activity that this agonist induces?
So, of course, we have tested the potency of pridopidine to activate the sigma-1 receptor in cells which do not have this mutation. And so there are many ways to evaluate how potent it is. And we see there is a very unique dose response to that, but we see a strong, almost complete activation. It's very potent. The way that we, for example, measure the activation of this receptor is to measure the when the sigma-1 receptor is in the cell in normal situations, it is bound to another protein which is called BIP, which keeps it inactive. But we see that when we treat the cells with pridopidine, it is completely dissociates. So all the sigma-1 receptors that are present in the cell are being dissociated from BIP and being activated. And we can measure it by many different downstream pathways.
Yes, thank you. So is that in fact the primary mechanism of action, which is to dissociate an inhibitory protein?
So after it dissociates with BIP, where it is located in the cell is called the MAM, the mitochondrial associated membrane. So it's basically an ER protein, highly concentrated in those areas which are very close to the mitochondria. In ALS, as well as in many other diseases, this MAM region is impaired, non-function, shortened. So what we think is that primarily pridopidine is restoring the MAM integrity, by that allowing proper calcium flow to the mitochondria from the ER and improving mitochondrial function, respiratory energy production, and reducing ER stress and providing overall additional benefit and survival to the neuron.
Thank you. Thank you. Wonderful. Well, I think we should move on. Our next speaker this morning is Dr. Angela Gaines.